we transition to our last panel, we have a special treat for you. After the short video, Dr. Pierre Theodore, who is Genentech's Executive Director of Patient Inclusion and Health Equity, will take the stage as part of our Summit Spotlight. You're in for a real treat and are also sure to leave this segment knowing a little more and thinking about what you can do to ask bigger questions. Thank you.
Why didn't the doctor believe me? Did I say something wrong?
Do we have to experience the same pain and bias as our parents and grandparents? What if they actually gave us access to those clinical studies we learned about and those cutting-edge medicines? How many lives would that save? How much longer would we live?
What if we asked the bigger questions and really tackled the root causes of systemic inequities in healthcare? People of color still do not receive equal access to healthcare. We're determined to change this.
A big hand for Dr. Pierre R. Theodore.
Good evening, everyone. It is clear that leadership is strong and evident tonight. I am delighted to be with you. My name is Pierre Theodore, and on behalf of the 2,500 employees of Genentech here in Northern California, and additionally the 100,000 of our employees worldwide with our parent company, Roche, we're absolutely delighted to be here and support you and engage in dialogue. You know, I was asked, in a sense, to give a somewhat of a straightforward discussion as to what health equity means. And it would be easy to default to all kinds of academic descriptions. But instead, I thought I might relate to you a little bit of my experience as a surgeon in Baltimore many years ago. And night after night, I would go down to the emergency room and I would take care of patients, each one of them suffering from gunshot wounds, but every single one of them African-American males, without exception. And there's no reason for that other than the political and the economic and the social environment that drove them to be at a higher risk for the disease of trauma. It had nothing to do with their genes. It had nothing to do with the health care. It happened to do with all of those things that are upstream that were driving those differences in healthcare outcomes. Now that's a very stark version of a health disparity, but health equity happens left and right. In cardiac disease, in renal disease, in lung cancer, cervical cancer, maternal mortality, in which the population we're part of, by virtue of our race or ethnicity, determines both the risk and the severity of disease. This is the essence of health disparity, and health equity is recognizing that upstream of the disease are all these factors that we need to address. And it turns out that the majority of what goes into defining health and well-being is not found in the healthcare system. It's not even found in the genes for a company whose very name is based on DNA. And we came to recognize as a healthcare organization, going beyond just bringing medicines to market, that to create healthy populations, we have to acknowledge these social, these political, and these economic realities that face patients, in particular, Black and brown patients. What I'd like to draw attention to is a few facts, because the lifeblood of our organization is bringing transformative medicines to market. And we know, for example, that about 91% of all the genomic material that we use to develop drugs and all the material that we use in order to determine the effect of the drugs on populations comes from patients from European ancestry. That Black and brown populations are severely underrepresented in trials. So on the one hand, there's a lack of availability to breaking technologies, and on the other hand, we don't know if some of the drugs that we bring to market might differentially impact one population versus another based on where they're from. In addition to that, we also know that many patients aren't even offered the opportunity to enter into a clinical trial, But ironically, when you ask patients, many of them would be willing to do so, and they're not being asked. And maybe part of that reason is because the number of healthcare providers that come from underrepresented groups is low. So the types of patients that types of physicians that the patients are seeing do not look like them. Look, we recognize that this is not a simple issue that we are trying to address. We won't get there with any single silver bullet. There's not any single drug that will address the issues of health disparities. And therefore, across health literacy and partnerships and making new investments in community-based organizations and partnering with each and every one of you, I should hope, we will continue to make inroads into offsetting some of these differences by populations, particularly for Black and brown populations. So look, our lifeblood is what we do through our clinical trials and through our clinical research. This is where we have to put our money where our mouth is. And here is the example of a few of those clinical research efforts that we put in place to address the needs of traditionally underserved populations. Whether it's COVID-19 and pneumonia, or multiple sclerosis, or diabetic eye disease, these are examples of trials where we have taken an additional effort to understand what are the barriers that are faced by populations worldwide and populations locally. There is an often well-worn phrase, right? That the arc of the moral universe inclines towards justice, but it doesn't get there by gravity alone. It takes each one of us bending that arc. And at Genentech, we are absolutely delighted to partner with each and every one of you as change makers. We appreciate your attention tonight and for having invited us to support you. Have a good night.